Good afternoon, everybody, and welcome to this lunchtime session. I'm really pleased to welcome everybody here today to this beginner's guide to genetics in cancer. And by the registration numbers, it would seem that everybody needs or wants to know something more about genetics. So I'm really pleased to welcome you all. For those of you who don't know me, I'm Nikki Lambert. I'm the Northern Cancer Alliance Clinical Lead for Nursing, and I'm going to chair this session today. I'm really pleased to welcome Jackie, and Jackie's going to be our speaker today, Jackie Cook, and she's Consultant in Clinical Genetics at Sheffield. Just a few housekeeping rules. Can I ask that people keep their microphones off? We love to see faces on Teams, so if you have a camera, please pop your camera on. There will be an opportunity for questions during the session and also at the end. And if anybody does have a question, pop it in the chat box and we'll monitor that as the session goes along. We will be prompting our timekeeping because we absolutely know how valuable your time is. So we will finish on time. And occasionally for these sessions, we do manage to give you 5 or 10 minutes back. So we'll see how it goes. So without further ado, I'm going to hand over to Jackie and she's going to present for this session. And this is where my IT hopefully works. While Jackie introduces herself, I'm going to share the slide deck.
Thanks, Nikki. So my name's Dr. Jackie Cook. I'm a consultant in clinical genetics in Sheffield, mainly working in cancer genetics. And the other thing that I am is the clinical director for rare disease in the North Eastern Yorkshire Genomic Medicine Service. So I've been asked to give you a talk on cancer genomics at a fairly basic level. So really to cover and be understandable, hopefully, for all of you that are here this afternoon and at a level that makes sense to you. I hope to leave plenty of time at the end for questions. There are a few kind of natural pauses within the talk. If there is a question that you have that you would really need to have answered now to make some sense of what I'm saying, then please put that in the chat, and that's being monitored so somebody can let me know if that should happen. So what I wanted to start off by doing is just giving you just a little bit of basic genetics so that what I then move on to talk about makes some kind of sense. I'm going to talk about the use of genomics in cancer itself, and then move on to talk a little bit about the much rarer cases of inherited cancer. So I want to kind of get things into perspective for you, first of all, before we go on to the really weird and wonderful. So I'm going to be talking about genes, and so I thought probably sensible to start off by explaining what genes are. So these are the instructions that we pass down, we inherit from our parents, we pass down to our children, and basically they are instructions on how to make the building blocks of our body, which are the proteins, and they're made up of this chemical called DNA. DNA itself consists of 4 bases, which we call ctDNA, and combinations of those bases make the genetic code, which in turn will then result in the formation of proteins. And because we get from most genes the same genes from our mother as well as our father, the majority of genes come in pairs. We have 2 of them. So genes make proteins, and proteins have lots and lots of different roles within the body. So they can be structural, they can be proteins that actually make the parts of our body. They can be enzymes, which result in the metabolic pathways that run everything within our body. They can be regulatory proteins, which switch other genes on and off, so they can be involved in embryogenesis and development of the fetus, and they can be involved in how things work in our body. Those proteins are made up of combinations of 20 different amino acids, and those bases in the DNA, the ctDNA, specify what amino acid is going to go at what point and where in the protein. And those genes, and we have about 20,000 human genes, those genes are packaged together within the cells on structures which we refer to as chromosomes. So chromosomes are just packaging structures, but the helpful thing about proteins is they're just about big enough to see. So we can look at them, and that was the very first genetic test that was identified. And so as humans, we have 23 pairs of chromosomes, and 22 of those are identical in males and females, so they're numbered 1 to 22. And then the last pair of chromosomes are the X and the Y, which determine whether we will be male with an X and a Y or female with 2 X chromosomes. So that's a very basic summary of genetics for you. So we can move on to the next slide. So I've still got the same slide on my screen. There we are. So actually the picture on the left is a diagram of what chromosomes look like within the cell. So my first thing that I want to say about cancer genomics is this statement, which is that cancer is a genetic disease, but very rarely inherited. So I need to explain that statement. So what is cancer? Why do we get cancer? The cancer is due to damage to genes within a cell. And if those genes are involved in cell growth and in cell regulation, then damage to those genes can result in that cell growing out of control. And that's what cancer is. Cancer starts off as a single cell that has lost its growth control and then starts to divide and get bigger and bigger and then become invasive. Now, there's nothing unusual about cells accumulating genetic damage, because that happens to all of us. And it's why we don't look the same at 60 as we did at 20. It's because we are accumulating genetic damage within all of our cells, some of which is repaired, but some of which it isn't. And that genetic damage is just a random event that happens to all of us. And it can take many forms. So it can be that damage results in the breakage of chromosomes. So we see breaks in chromosomes, we see chromosomes rearranged between each other. It can result in loss of genetic material from the cell, so we just lose great big bits, or duplication of that genetic material, so we have more than we started off with. Or it can involve specific genetic mutations, so very subtle changes in those arrangement of bases within the gene, resulting in abnormal proteins. The damage can occur in any single one of those 20,000 genes, but if they occur in genes that are involved in cell growth, so quite a specific number of cells within the cell, then that can result in loss of control, and that cell's starting to grow out of control. And we often refer to those as driver mutations when we're thinking about what are the mutations within a cancer cell. And usually those gene changes are confined to the tumour itself. So if you were to look in a normal tissue or in a blood sample, you wouldn't see that particular change in the gene. It is just confined to the cancer. And we call those somatic variants or acquired variants. Next slide, please. So, okay, I've just said we're accumulating all of this genetic damage within cells. Well, how does that happen? Why does that happen? And there are a number of reasons. It can be internal within the cell. So there are lots of chemical reactions going on in cells, and some of those cause changes to our DNA, such as loss of amine, so deamination or oxidation or alkylation, a lot of which is repaired, but if it isn't repaired, then that will result in a permanent damage to that gene. But there is also a lot of things that we are exposed to externally that cause genetic damage. And I've written some of the more common ones here. The first is radiation from the sun. So that radiation causes genetic damage. If we expose our skin and get sunburn and skin damage, then that will result in damaged genes within our skin cells, and those are the drivers for the skin cancers that are related to sun damage, such as melanoma and BCCs. And those cancers are more common in sun-exposed areas, particularly on the face. We all know that cigarette smoking is responsible for most lung cancer, and there are carcinogens in cigarette smoke that cause genetic damage, and that's why it causes cancer. And of course, you're inhaling it into your lungs, so that's where you're going to get the cancer. There are certain ingested chemicals that are then passed in the urine into the bladder, and they can cause bladder cancer. We know that asbestos can cause a type of tumour involving the lungs called a mesothelioma, and that is due to the inhalation of asbestos fibres. And we know that viral infections can result in genetic damage because viruses enter the cell and then incorporate into our DNA. And the classical one there is the human papillomavirus and cervical cancer. So we're all exposed to all of these things. And so it is not surprising that we will accumulate damage as we age. And one of the reasons why cancer usually occurs in older people is that because it just takes time to accumulate sufficient genetic damage to cause a cancer. And therefore it is age-related often. New slide, please. So what some very clever scientists can do is they can look and then analyse all the different genetic damage within a cancer cell, and they create these pictures which are called mutational signatures. And I'm not going to go into any great detail here, but you can see on the outer ring you've got the chromosomes. The inner squiggles are a picture of the chromosome rearrangements between different chromosomes in the cell. And then as you go out, these are different types of genetic damage. These include the deletions and the duplications, and then the more subtle point mutations within a cell. And this is very much a research tool at the moment, but we are learning a lot by just looking at what type of genetic damage occurs within cells. And we're beginning to realise that the genetic damage is often unique to particular cancer types. And even within a cancer type, such as breast cancer, genetic damage that we can see can help differentiate between what you might see in a HER2-positive breast cancer from one that you might see in a inherited BRCA mutation type of breast cancer. So mutational signatures can be quite specific. Again, you see in the sun-related damage ones, you see a particular type of damage to the genes, and that again is reflected in the mutational signature. So we know that cancers, the type of genetic damage within cancers does vary according to the type of cancer that it is. New slide. What are the genes that are the ones that, if they get damaged, are going to result in uncontrolled growth? They tend to fall into two groups. The first we tend to call tumour suppressor genes. These are genes that we all have, and when they're working normally, they protect us against developing cancers. Now, why do they protect us against cancer? That's because of the job that they do. So some genes are involved in controlling cell division to make sure that a cell divides when it's meant to and not at any other time. Other genes are involved in repairing damage to DNA. And some of these genes we're going to come back to at the end of the talk because these are the inherited cancer genes. But what they're doing when they're working normally is identifying damaged DNA and repairing it. If they don't work, then obviously that's going to result in the accumulation of more genetic damage within cells. And there are other genes that make sure that a cell dies when it's meant to do, because, for example, it's full of genetic mutations. And that if that's not working, then that controlled cell death doesn't happen. And an example of that gene is TP53 gene. So we call them tumour suppressor genes because normally they prevent us getting cancer unless they are damaged. And then there are genes called oncogenes, which are genes that, when they are mutated or damaged within a healthy cell, can cause that cell to grow out of control. And an example of an oncogene is the HER2 gene, which, when amplified so that a cell develops multiple copies of HER2, is associated with breast cancer. Next slide, please. So what does the genetic damage, what do the mutations that we can identify in the cell, what use is that? What can it tell us? Why would we be interested other than knowing that that's what happens in cancer? Because usually the diagnosis, is this a breast cancer, or is this a lung cancer, or is this a colorectal cancer, is usually obvious clinically. Therefore, you wouldn't need to know what the mutations are to tell you actually what it is and where it is. What it can do is help us with classification of tumour subtypes. I've given here a very rare example only because I saw a child with this recently with a craniopharyngioma, and analysis of the mutations within that brain tumour showed that there was a mutation in a gene called CTNNB1, and we know that you see that in association with a particular type of craniopharyngioma. So it allowed us to subclassify that diagnosis. Where it can be helpful in diagnostic terms is when we don't know where the primary comes from. So sometimes people present with metastatic disease and it's not at all clear where it started. And by looking at the mutational signature within that cell, sometimes that can tell us where it started. So perhaps at this moment in time, a fairly limited application in terms of diagnosing what type of cancer it is. What it can help with is tell us a little bit about the prognosis of that cancer, because we know that if we find particular genes damaged within that cancer cell, that gives us some information about how that cancer is going to behave. And so I've given an example of a KRAS mutation in colon cancer. And when we see a KRAS mutation in colorectal cancer, we know that that is associated with a poorer survival and an increased tumour aggressiveness. So it can give us a bit more information about whether we're dealing with an aggressive cancer or a more or less aggressive cancer. Next slide. But I think really where this is going to come into its own is what the specific knowledge about mutations within cancer cells can tell us about treatment. And this is the growing area of cancer genomics at the moment. Because at the moment, our treatment of cancer, surgery, radiotherapy, chemotherapy is really aimed at killing the cells that are growing fastest. But that means that it will kill all cells, and therefore there are a huge number of side effects from those treatments. And our hope is that we kill more cancer cells than we kill normal cells by the treatment. Where we really want to be getting to is a point where we can target the cancer itself without affecting the normal tissue. And if we know what the mutations are within the cancer, then we can start to target those with specific drugs that just will kill off the cells that carry mutations in those genes. And this is known as precision medicine. So, for example, in lung cancer, we look for specific mutations in 3 genes, in EGFR, KRAS, and ALK. And if we find those, that will tell us about specific chemotherapy regimes that we might use that might target those cells. And the number of drugs that are being developed now that target specific genetic changes within cells is increasing exponentially. So a lot of these treatments are now going through NICE for approval. And these drugs are given when you know that a cancer cell contains a specific change. And it's a branch of pharmacy that's known as pharmacogenomics, expanding rapidly. Another example is in breast cancer. And as you will know, those of you that deal with women with breast cancer, we look at a number of things on tumor. We look at estrogen receptor status, progesterone receptor status, but one of the things we look for is amplification of the HER2 gene. Because we know that if we see that, we can use a drug called Herceptin, which targets those cells with HER2 amplification. So again, another example of precision medicine. New slide, please. So where we are at the moment is that we're beginning to learn more and more about what causes cancer. We're learning more and more about specific changes that occur within cancer cells. And what this is beginning to do, and what it will continue to do, is give us more and more options that we have for our patients. Hopefully better options with better outcomes and less side effects. So that's the goal, that's what we're aiming for, that's why all of this is being developed within cancer services. But what actually does that mean for cancer services themselves going forward? Because at the moment, we don't really have the setup and the pathways that are going to enable all of this genomics to happen easily. Next slide, please. So first of all, how is this going to affect our pathology services if we are going to start moving towards investigations that are looking more and more at the genetics within cancer cells? First thing that we have to do is look at our pathways, because we are very used in surgery to taking out the tumour and sticking it in a bucket of formalin and sending it off to the pathology lab. Now, DNA and formalin really don't go very well together. And what formalin does is it breaks down the DNA within the cells, which means that you can't analyse them and you can't identify the damage. And so one of the things that we're now having to think about is our pathways from theatres to pathology labs, and how we can get those tumours to the pathology lab intact with DNA that we can then extract, which enables us to do that testing. The pathology labs themselves are having to think about new ways of dealing with cancer as it comes in and developing pathways within the pathology labs. And to aid with that, NHS England are developing specialist pathology centres, which they're calling cellular pathology genomic centres. And there's going to be one of these for each cancer alliance. And so this is a pathology department that is dedicated for the region that they cover to deal with the specimens where we're going to do genomic testing, either within the laboratory itself or preparing the specimens so that the DNA can then be passed on to the laboratories, which are known as the genomic laboratories within the region that are actually going to do the genetic testing. So that's ongoing at the moment. We're starting to develop those centres. For North Eastern Yorkshire, we will have 4 of them based in the main hospitals, covering the 4 cancer alliances. And those centres will then also be the centres in which we will start to really develop the clinical trials that we need to look at these precision treatments. And there's something also that's happening at the moment called the Cancer Vaccine Launchpad, and that is looking at how we can use messenger RNA vaccines to perhaps develop or create a way in which our bodies can start to fight the cancer itself using our own immune systems, based on our knowledge of what the genetic changes are within the cancer cell. And of course, the other development that's going on at the moment that is going to feed into this huge expansion of cancer genomics is the development of very close links with the laboratories, so that we've got very close links between pathology, between the cancer services and the genomic laboratories within the region, with the main hub laboratory being in Leeds. And they themselves are having to bring about a huge amount of changes and developments within the laboratory setting. Next slide, please. So they are facing a significant decrease in the amounts of cancer genomic testing that they are doing. And in order to do that, we need to utilise new technology that allows us to analyse very large numbers of samples at speed. And so I've put in it a picture of a machine called a NovaSeq. And this has just gone into the Leeds lab. And the NovaSeq allows us to sequence huge amounts of genetic data on multiple samples all at the same time. Kit like this is a bit like computers. The more it can do, the smaller it seems to get. So a machine like this a few years ago would occupy a whole room. Now it looks like a bit like a cupboard. But these kinds of machines, which are constantly changing as the technology changes, will allow us to ramp up the amount of genomic testing that we are doing in cancer. Because what is important is that we can do this in a timely manner so that we get the results out of the lab to the doctors who are going to be deciding on treatment at the point where that treatment decision needs to be made. If we are not producing samples till 2 or 3 months down the line, that is no help to anybody. We've got to produce these sample results at speed. And it is machines like this that are going to allow us to do that. New slide, please. I'm going to take a break in a couple, I think this is my last time, then I'll just give a break just in case anybody wants to ask a question at this point. Otherwise, I will carry on. But I just want to cover another technology that some of you will have come across, particularly those of you who are working in lung cancer services. And that is something called ctDNA, or circulating tumour DNA. So I just wanted to explain what that was, if this is something that you've come across. So if you look at the blood from cancer patients, you will see a number of things. You'll see normal blood cells, you expect to see. Cells break down and they release their DNA into the blood. So you will also see circulating free DNA from cells as they break down. And in addition, what you'll see in patients with cancer is you'll also see circulating tumour cells that have broken off from the cancer itself. And again, they are releasing DNA into blood, and this is called circulating tumour DNA, ctDNA. So what you can do is something called a liquid biopsy, and you can take a blood sample from a patient with cancer, and you can isolate from that blood sample the DNA that has come from the tumour. And you can look at it and you can analyse the genetic changes within that DNA. And that can be we use it in lung cancer now because sometimes lung cancers are quite difficult to get at because they're deep within the lung and the biopsies are often small. And so it sometimes is easier to look at the circulating tumour DNA rather than the tumour itself. And again, what that allows us to do by looking at the damage within the circulating tumour DNA is to guide tumour-specific treatment. The other thing that it can do is help us monitor treatment, because what we should be seeing if we're getting a response to our treatment is a reduction in the amount of circulating tumour DNA in the blood. And it can also help us monitor remission, because if the patient is in remission, we shouldn't see any ctDNA in the blood. So we can use to track progression of the disease and the progression of the treatment by monitoring the ctDNA. Right. I think, Helen, there are some questions, is that right?
So there's just one in the chat at the moment, and it's more of a general question rather than to anything specific that's been said so far. So just why maybe Jackie's answering this, if anybody's got any questions that are specific to what's been said so far, that please feel free to put it in. So if there's any terms you don't understand or anything that's left you a bit confused, then please feel free to ask it in the chat. We're keen for any questions at all. And if you've got a question, then somebody else will probably also have the same question. So but the question that we have, Jackie, is it's a bit more of a broader question, but it's from Patrick that says, can you say something about the changes which will happen when the Gallery trial is rolled out?
So the answer to that is I don't know the question. I don't know the answer to that. So this is the trial that they're looking at, taking blood samples from individuals to look for tumour DNA. People who have not been diagnosed with cancer, and the aim of that is to try and identify cancer at much earlier stages than normal. And I think the jury is out on that one. I mean, in theory, it has huge amount of potential. How are we going to get that to work in the NHS when we're all under such a huge amount of pressure, just dealing with the day job and the cancers that are coming in? I don't know. I think the other thing that there is it's best at picking up advanced cancer, of course it is, because that's when you have the most damaged DNA within the blood. So I think we still don't know how good it is at picking out the very, very earliest stages. So there are lots of ways of picking up advanced cancer other than doing ctDNA. So I think I can't answer the question really. I think we just have to do the trial and see where it takes us.
Yeah, and see how that then is going to be implemented as well.
Yeah.
I guess there's so many different techniques coming in at once. It's not clear which one, how they're going to kind of work and be implemented, as you say, kind of on a larger scale. There's one more question as well that's been put on about how does this help blood cancer chemo treatment? I'm wondering whether maybe that's more relevant to the ctDNA.
Yes, so in leukemias and lymphomas, there's a lot of genetic testing going on at the moment. Again, looking for particular mutations that will guide treatment. That's being done both on blood and on bone marrow. And that's probably one of the areas that's expanding most rapidly at the moment. But yes, it is just it's used just as much as it is in solid tumours.
Great, thanks. And then maybe one quick more, and then we'll move on. There is a couple in there, but if we just do one more, and then we'll maybe do the others in the next pause. Is that you mentioned about there being pathology centres in the main 4 hospitals in the region? Could you just say which hospitals those are going to be, if you know which ones those are?
So in the North East and North Cumbria, it's going to be Newcastle. In the West Yorkshire, Harrogate, Cancer Alliance, it will be Leeds. In the North Yorkshire and Humber, it will be Hull. And in South Yorkshire and Bassetlaw, it will be Sheffield.
That's great. Thanks
and
very
the
much.
Hospitals in those areas will direct their samples that require genomic testing into those labs.
Great, thank you.
And the one on lung cancer I'm going to come up to. So if we move on to the next slide. So I've been talking about cancer and tumours. I'm going to move it out now to cancer and families. So I think the first thing is some statistics. So 1 in 2 people will develop cancer at some point in their lifetime. So there are hardly any families now that do not have cancer in their family. We all have a family history of cancer. We're going to, if 1 in 2 people are going to get it. We know that some families, it seems to be the same cancer that's occurring. Now that's usually the common cancers. So it's usually lung, breast, colorectal, prostate. 1 in 7 women will get breast cancer. 1 in 7 men will get prostate cancer in their lifetime. So if you're going to see a cancer occurring more than once in a family, it's going to be those common ones. It's not just cancer. You see exactly the same thing for all common diseases. So you see that type 2 diabetes, you see that in coronary artery disease. It clusters in some families, and some families never have it, and other families have loads of it. It tends to occur at the typical ages for those particular cancers when it is cancers. Now, this is due to the fact that we all have variations within our genes. So if we look at our 2 copies of each gene, they're not identical to each other. If we look within a population, we will see the same genes, but slightly different variations in those genes. And in cancer genes, the genes that are involved in cell growth, some of those variations make us more likely to get a particular type of cancer, and some of those variations make us less likely. And so the reason that some families are more predisposed to some conditions and not to others is not because of a single gene, but because of multiple genes. And each of those genes has a very small effect. So on its own, it's going to make absolutely no difference to your risk at all. But if you add them all together, and then you add in a shared environmental factors that recur within families, so you get something called multifactorial polygenic inheritance. And that is why we see clusterings of particular types. So there are some families that maybe have a slightly higher risk of getting breast cancer than others, but a lower risk of getting colorectal cancer. And it's because of our background genes and the genes that we share as families. This is not single high-risk genes. Next slide, please. I think I probably just said exactly all that. So let's take lung cancer. We know that lung cancer is related to smoking. We know that some families have a lot of lung cancer in them, and that is, and almost all of that is still due to smoking or passive smoking. And then we see other families that you don't see any lung cancer at all, and you've got smokers in those families who are smoking heavily and never get lung cancer. We've all had patients sitting in our clinic going, you can't tell me, doctor, that smoking causes lung cancer because my father smoked 90 cigarettes a day for 60 years and he never got lung cancer. And we've all been there, and we know that that is actually true. That is the case. What is going on is that lung cancer, smoking causes lung cancer, but whether you're going to get lung cancer by smoking depends on your background genetics. It depends on all of these genes adding up that make you more or less susceptible to getting lung cancer. So if you come from a family where there are genes that make you more susceptible and you smoke, you have a much higher risk of getting lung cancer than if you come from a family where actually the sum of your genes and genetic variants makes it less likely that you would get lung cancer if you smoke. Of course, the best thing to do is not smoke at all, no matter what your family history is. But if you have a family history of lung cancer, the most important thing that you can do is not to smoke, because you come from a family that is going to be susceptible to smoking. So I hope that makes sense and answers the question that was in the chat. We go on to the next slide. Some of you might have heard this term, polygenic risk scores. Now, polygenic risk scores, again, at the moment, are a research tool that may come into its own in the future. Polygenic risk score is the total number of genetic variants that an individual has that can increase their risk of developing a particular disease. Now, we're still learning here. We don't know the half of the genes that make us more or less likely to get particular conditions. So at the moment, this is a really rough and ready figure. Don't get me started on 23andMe or Ancestry and the information that they give you, but they give a lot of information on using polygenic risk scores. And most of it is not to be believed because we just do not know enough about the risks. But you can use the information that you have on genetic variants within a family, combine that with the environmental factors such as whether somebody smokes or not, and you can use that to generate a kind of relative risk of how likely or not likely you are to develop particular types of cancers. Now, ways in which that might be used in the future is you might use that to target screening. For example, in breast screening, if you generate a polygenic risk score, depending on the variants you have in your genes that make you more or less likely, combine that with the risk factors that we know increase the risk for breast cancer, such as obesity and use of estrogen, postmenopausal, yeah, HRT. And you could add all of those together and you could say, right, well, at this level, we're going to start off for a new breast screening. So some women may stay at the 50, which is open to all women. Some women have got a very low risk of developing breast cancer and they may not need to be screened until they get to 60. Other women are going to have a much higher risk, and we might want to start earlier at 40. And we already do this based on family history, which is a kind of rough and ready measure of your polygenic risk score. But it could be refined in the future, and that may be something that we do in 10 years' time. But as I say, these are early days, and we really need to have much more information before we start providing information that is beneficial and not harmful. Because if we tell people the wrong thing, that can be misinterpreted, and that may not be a good thing, and we should above all do no harm with the information that we give to patients. Next slide, please. So I have said that most cancers are due to acquired somatic mutations. All cancers are genetic, most are not inherited. Very rarely, cancer can be due to an inherited, what we call germline or constitutional mutation. That is a mutation that is not just in the cancer cell, but it is in every single cell of our body because it came down to us either in the egg or the sperm cell. Most of those germline mutations, when we're talking about cancer, are in just one of the two copies of that gene. So you have one normal copy and one faulty copy, and you'll find that gene fault whether you look in a blood cell or a lung cell or a skin cell. Next slide, please. To explain why inherited genes like this cause cancer and why they tend to cause cancer at younger ages, we have what's called the two-hit hypothesis, which was first described by a doctor called Dr. Nuts. And this is what we believe is going on, is if you go to the bottom of this picture, in the normal non-inherited cancer, you get a fault in the first copy of the gene, and it's when you get a fault in the second copy of the gene and you lose all normal functioning gene, that's when cancer kicks off. So in inherited cancer, when one of those gene faults is already there in every single cell, you only need to get a second fault and one more fault in the second copy of the gene for the cancer to start. So you are one step ahead in the game, if you like, which is why what you see in inherited cancers is they tend to occur at younger ages than the normal age to develop a particular cancer. Next slide, please. So the commonest inherited cancers that we see are either breast and ovarian cancer, and these genes account for about 5% of all breast cancer. So back to me saying again, most cancer is not inherited. Slightly greater percentage of ovarian cancer, about 10 to 15% of ovarian cancer. The next commonest one that we see is inherited colorectal cancer, which we call Lynch syndrome. And that accounts for about 2 to 4% of all colorectal cancer and about 2.5% of uterine or endometrial cancer. So these are the common ones. There are a number of vanishingly rare cancer syndromes with very unusual tumor types, which is the type of thing that I do in my day job. But these are really, really rare, and most doctors will not see these conditions. Next slide, please. So inherited breast and ovarian cancer, I think most people have heard about that, and I think this is the thing that most women who develop breast cancer worry that they might have, and of course they're not. Most of them are not going to have that. So as I said, it accounts for about 5% of breast cancer and 10 to 15% of ovarian cancer, and there are 3 genes, high-risk breast and ovarian genes called BRCA1 or BRCA1, BRCA2, and PALB2. We all have them, we all have 2 copies, and the families that have inherited breast cancer have a fault, an inherited fault in one of the 2 copies of the gene. And what we see is that we start to see in these families women who are diagnosed with breast cancer at quite young ages, often under 40, the youngest I've seen is 17. Much more common to get triple negative breast cancer, so estrogen receptor negative, progesterone negative, and HER2 negative. Very rare for a HER2 positive breast cancer to be inherited. And obviously, because this is a high risk in families, we start to see the family histories. And they're usually quite significant family histories. And of course, we can see it on both the maternal or the paternal side. It's come from one or the other. But men have these genes as well as women. They may not be as high risk because men can get male breast cancer. But you've got to look at both sides of the family when you're taking into account the family history. And for the women who have a fault in one of these genes, their lifetime risk of developing breast cancer is somewhere between 50 to 70%, compared to the population risk for most women, which is around 13%. So these are high risks. And in ovarian cancer, the lifetime risk, depending on which gene, highest BRCA1 is between 10 to 14% compared to a population risk of 1 to 2%. Next slide, please. So we need to try and identify these families, because these are the families that will benefit from taking some action before they get cancer, if possible. And the way that we identify it at the moment is based on their family history, on their age of diagnosis, on the type of cancer that they have, and more on some of these genetic tests that are occurring within the tumour. And particularly in ovarian cancer, all ovarian cancers are now offered genetic testing. And And taking all of that information into account, we can work out how likely a woman is to have an inherited type of breast and ovarian cancer. And when that likelihood goes above 10%, then we will offer them diagnostic testing on a blood sample to see if we can identify anything in the gene. If we can, then that enables us to do what we call cascade testing for all the other family members to see within that family who has and who has not inherited that gene mutation. We have to know what we're testing for. So we have to have identified the mutation in an affected woman before we can do any testing of unaffected family members. And then we have a group of women and also, of course, men. And it's important that the men know what their status is because they're going to have daughters who they could pass this on to. And then we can offer those women screening. We normally start between about 25 with MRI breast screening. And we can start to talk to them about risk-reducing surgery if that's what they want, either to have their ovaries removed or to have bilateral mastectomy and breast reconstruction. But this is rare. But it is important to identify these families. Next slide, please. Lynch syndrome, inherited colorectal. I've already told you how common it is. Again, 3 high-risk genes, MLH1, MSH2, and MSH6, and a moderate risk gene, which is PMS2. Again, it's dominant inheritance 1 and 2. Again, I'm diagnosed at young ages. The average age is in the mid-40s. It's associated with these significant family histories of bowel and endometrial cancer. And the risks that these individuals have, lifetime risk of bowel cancer is about 40 to 70%, population risk of 5%, and in women, 40% risk of endometrial cancer, with a population risk of 3%. Next slide. Now, what we do for Lynch syndrome nowadays is all colorectal cancers now have tumour testing. So we do a number of tumour tests, and those of you in this area will know that we do tumour tests, including immunohistochemistry for the proteins and MSI test. And if that tumour testing suggests that this could possibly be Lynch syndrome, and you've got to bear in mind that not all the people who have these gene changes in the tumour will have it inherited and have it in the blood. Some of them will. But if we find something in the tumour that suggests that it may be inherited, we then go on and look at blood samples to see if it is in the germline. And then once again, if we identify that, we can start to identify the affected family members, cascade test through the family, and offer those affected, the individual who carry the fault, screening, which is usually colonoscopy every 2 years. Next slide, please. So cancer genomics is starting to and will continue to revolutionise the management of cancer. I think it's a really exciting field of medicine at the moment. I think it will lead to much better treatments and hopefully much better outcomes for patients. But my final slide is to bring you all down to earth. So if I could have that final slide, please. Prevention is better than cure. The fact is that 30 to 50% of cancer is avoidable. Not by any fancy thing to do with genes. The way that we avoid it is by maintaining a healthy weight, diet and exercise, not smoking, limiting your intake of alcohol, and protecting your skin against sun damage. So we can spend lots of money on genetics, but actually where we perhaps should be spending the money is in schools, teaching children about the importance of diet, healthy diet and exercise, banning smoking completely, trying to introduce some moderation when it comes to drinking, and making sure that everybody wears high factor suntan lotion. And that's the reality of it, 30 to 50%. I'm going to finish there.
Fantastic. Thanks ever so much, Jackie. That was brilliant. And I particularly like that last slide of bringing us back down to earth and the factors that you considered there. We've got a couple of questions still in the chat. So we'll go through those in order. If you do have any questions for Jackie, now is your opportunity. Lots of claps coming in. So lots of praise there, duly deserved. If you've got any questions, then just put them in the chat. You can raise your hand if you want to, but I'm not quite sure what order those will go in. So we'll do the questions in the chat first and then maybe come to raised hands. So the first one from Sarah Scargill, it says, are you seeing increased sensitivity of detection of tumour DNA as laboratory equipment evolves?
Yes, it is getting better, and we are kind of going down to very, very low levels. We're never going to be in a situation where we can, it's got to be at a level that we can pick up, but it's getting better. So we are seeing increased sensitivity there.
Great, thank you. And I guess these are so tight, you know, what always amazes me is, you know, how much we're looking at. These are tiny, tiny amounts of DNA.
Tiny amounts
so
of
it's
DNA.
making sure that because we're using such small amounts, that we're using them in a reliable way. And I guess as the technology improves, it's the reliability that increases, that comes with the sensitivity of the technologies. So I hope that answers that question. Next one comes from Irene, is how many patients referred to the how are patients referred to the cellular pathology genomic centres?
That will be done. That will be a decision within pathology, within the district pathology departments. And so what we need to do is get the message out there about what is available and the pathways that you need to get. So that's a piece of work that we are already doing. There is so much education that is needed in this area because most of us that work in the NHS have never done any genetics at all. So we're not starting off at a kind of high level. We're starting off at a fairly low level of knowledge, and we've just got to get the message out there. So pathology departments will make the decision about whether that sample needs to go onto the main centre or not. But within those district hospitals, we need to make sure that it's getting to those pathology departments in the right way so that we can actually do that.
Great, thanks, Jackie. Maybe that's something that we could maybe look at for a future lunch and learn or an education session, that we could maybe put that together with those new pathology centres. A question now from Adrian. So with regards to smoking and lung cancer, we've had that one. We have, yeah, sorry, I even ticked it so that I wouldn't come back to it, and I still did. So there's a comment here from unknown user. So I'm not NHS, but research scientific academic, and we teach biomedical science at our uni. Hence my interest in this webinar. Not sure whether this is useful. We collect in surgical samples. I'm just trying to speed with this. So I think that's more a comment, and there's a link there for anybody who wants to explore that. And just lots of votes for sessions that people would like to see. So we'll put that back up in a moment. So so the votes that people are voting for, it flashed on quickly. The slide, we're taking feedback from you of what topics you would like to see in future, because we really want to make sure that these lunch and learn sessions are as useful as possible. So there's a question from David, which says, how can we get the message out there into the communities that 30 to 50% of cancers are preventable? It feels like it needs a national drive or regional drive from cancer alliances, perhaps. And I'm unsure if the average patient knows this. I don't know whether, Nikki, do you want to come at that from a Cancer Alliance perspective?
I can do. First of all, many apologies for the IT blip. I do apologise, Jackie. Overzealous moving of slides, so I'm so sorry. I guess, my colleagues are on the call from the Northern Cancer Alliance. I guess it's a general comment, really. I think we repeatedly, and that's the royal way, I think, from a national perspective, from a local perspective, from even down to primary and secondary care perspective, we try desperately to try and drive this message home through social media, through cancer campaigns, etc. And you're right, it's how much of that message is taken on board, or how much of that message is heard. And I guess what we're trying to do is work round ways of actually constantly driving that message home through our clinicians, through our lay reps, and through the national agenda. So we're happy to work with anybody who wants to support that agenda, who has any thoughts and any ideas. You know, we're always listening for ideas to do that, but it's a really difficult question to answer, and it sounds like I'm skirting round the corners, but actually it's a major problem nationally about what people hear. I think cancer is still such a feared word in the community, despite the fact that we know more people live with their cancer than die from it now, despite all the new wealth of technology and medicine that's coming up. But I think it's still a real fear. I noticed Hassan had his hand up and he might want to add to that. So I don't feel like I've answered your question sufficiently, other than it's a constant it's a constant changing of trying to send the message out.
Hassan, did you want to come in there? Not sure. Just so we've only got a few minutes left, so I'll maybe just add to that if Hassan isn't able to. That I agree, Nikki. I think it's maybe something that it's across all professionals that we just need to sing from the same hymn sheet. And again, about being very clear that when genomic testing is offered, about being clear about what it can and can't do, and the fact that genetics is not the magic answer, but there are other factors that play. Hassan, are you unmuted now?
Yeah, can you hear me?
We can, yeah. We can.
I'm so sorry about that. I'm driving. I didn't want to miss the webinar, so I'm listening to it while I'm driving. Really informative webinar. Thank you so much for putting this together. But just on what Nikki was said, completely agree that this is a really broad topic in terms of prevention, not just for cancer, but for all conditions, for COPD, for diabetes, for heart disease. I mean, obesity, smoking, maintaining a healthy weight, exercise. These are messages that should be drilled into children from a very young age, and we're trying everything we can in primary care to get this on the agenda and to reinforce this wherever we can. But I suspect it's going to be something that's going to be lifetimes of work for many people to try and get this improvement. But I really love that message of getting it out there, that how much cancer is preventable with small lifestyle changes, and that's something that we should really cling on to, try and promote wherever we can.
Yeah, fantastic. Thanks, Hassan. Thanks. So we've got 2 extra questions in the chat that we've got 3 minutes in total to try and get through. But the first one is there the bioinformatics support for processing the sequence data as the number of samples and the speed increase?
You could answer that one, Helen. The answer is no, and we are doing our hardest to try and increase it, and loads of things going on at the moment in terms of getting more people into training, more education, encouraging people to go into jobs in the labs. Massive amount of work, because we do not at this current time have enough.
Yeah, and they're such specialist roles, and to be able to interpret all the so the sequencing and the machine that you saw, putting the sample in and getting the data out is a simple bit. Working out what that data means is a real skill, and takes many years of training. And so with genomics coming in so quickly, there is that kind of chicken and egg situation where we're still kind of building up our own internal workforce to address this, but in time, hopefully, we'll get there. And then the last question from Louise is, do you think there needs to be more education around ultra-processed food?
Well, this ties into diet. So we know that colorectal cancer is increased by very processed food, and so again, it's back to education, and it's educating young children about healthy eating habits, because what you eat as a child is going to affect whether you get colorectal cancer as an adult.
Fantastic. Thanks, Jackie.